My name is Sophie Knipper, and I'm originally from Hamburg, from the Martini Clinic, and right now I'm doing a robotic fellowship with Professor Waltz at Marseille. Well, what we did was we looked at all consecutive patients that were operated with a radio-guided surgery in Munich and in Hamburg between 2014 and 2020. Those were a group of a little bit more than 450 patients, and some of them were excluded due to inclusion of a prospective trial, or because they didn't want data collection, or they were taking ADT. So in the end, we had a group of 364 patients that were analyzed in this study. And our main outcome of interest were the oncological outcomes, namely the biochemical free survival and the therapy-free survival. And what we found here was that at 2 years of follow-up, 32% of patients were free of biochemical recurrence, and 58% of patients were free of therapy after the radio-guided surgery. And when we looked at this in a little bit more detail in the multivariable analysis, we found that a higher PSA preoperatively, more PSMA-PET avid lesions, and a localization outside of the pelvis, or a combination of retroperitoneal and pelvic localization, were at higher risk for having a biochemical recurrence or a therapy needed after the surgery. Well, in case of recurrent tumor within the extended pelvic lymph node dissection template, we performed salvage lymph node dissection of the whole template of that respective site. And in some cases, also for the contralateral site. That was a little bit according to the surgeon's discretion. When the suspicious lesion was located elsewhere, so for example, pararectal, we resected the corresponding region and also the surrounding tissue of that region. And if retroperitoneal lesions were found, the dissection template typically used for testicular cancer patients was resected. Well, I think the indication for salvage lymph node dissection should probably be reserved to the candidates that are, well, at least according to our results, best suitable. So that means patients with a low preoperative PSA, with a low number of PSMA-PET avid lesions, and ideally located within the pelvis. We currently don't add ADT to those patients, so salvage radiotherapy, in comparison to that, has certainly a broader spectrum of indications, and mostly it is combined with ADT. So when we discuss salvage lymph node dissection with our patients, it's mostly, or most of the patients already had local radiotherapy, so it may be patients for whom the radiation oncologist don't feel that another radiation therapy would be appropriate, or in patients where critical structures such as the intestines or the ureter is very close to the PSMA-PET avid lesions. And in all other patients who did not have previous radiation therapy or who could be re-radiated, of course, salvage radiation therapy is always an option. However, we kind of feel that this would also be an option after radio-guided surgery. So certainly if you operate first, the tissues would be easier to operate it, or probably with less complications than if you have a pre-radiated tissue. So we discuss this very openly with the patients, and then decide together if they want to start with radiation therapy, if possible, or if they want to start with a surgery and then have the radiation therapy afterwards still as an option.